Hey everybody, we are going to be talking about obstetrics, which is the care of the woman in pregnancy, so during pregnancy as well as the postpartum period. So pregnancy is a period of 40 weeks from the day that conception takes place. Postpartum period is the 6 weeks following labor and delivery of the fetus. And this is when the mother's body in those first 6 weeks is returning back to that pre-pregnancy state. So visits with the provider for prenatal and postnatal care are very important. So that includes the initial prenatal visit, all of the following subsequent return visits, as well as a 6-week postpartum checkup. So all of these visits are included in that. The initial prenatal visit is of the utmost importance. So this may even occur while the female is trying to conceive. So it doesn't necessarily have to be when the patient finds out that she's pregnant, but it can be during those kind of planning periods as well. Here we're going to take the patient's history and learn about any risk factors, do a physical exam, make sure that the patient is healthy. We're going to do laboratory tests to also check for different things and discover the gestational age of the fetus. So again, if the patient has like a home pregnancy test, they're going to check for that gestational age based on the date of the last menstrual cycle. Sometimes they'll even go ahead and do an ultrasound, especially if the patient is at high risk, but trying to track that gestational age of the fetus. And then patient education at this point in the prenatal visit is of the utmost importance. It's crucial because, as you may know, there are many changes that the patient needs to make, perhaps regarding their lifestyle choices during pregnancy, right? So abstaining from alcohol use and smoking cigarettes, other illegal drugs, watching what they eat, maintaining a healthy diet, trying to avoid issues like gestational diabetes and such. So this portion, this patient education, is so important during this stage. So the patient will come in for that first initial prenatal visit. And then throughout the pregnancy, there are times when they have to come back for those subsequent visits. And here there's a timeline for each of those visits. So between weeks 10 and 14 of the pregnancy, they're going to come back. And what they're going to be looking for is they're going to be looking at vital signs. They're going to be measuring weight, and this will continue throughout the entire pregnancy. They're going to be looking at those lab results from the prenatal visit and assessing fetal heart tones. So this 10 to 14 week range is probably the earliest that you can assess fetal heart tones using what's called a Doppler, a fetal Doppler, and that picks up the heart tones through the patient's abdomen. Weeks 15 to 18, we start having monthly visits. And so here you're going to be, again, looking at vital signs, measuring weight. We're wanting the patient to gain weight, but not gain too much weight, right? We're measuring the fundal height. This is the top of the uterus. And they do that. The provider will measure this, but it's measured from the top of the pelvic bone to the top of the uterus. So as baby grows, the uterus expands, right, to make room for the baby, and then they measure the top of that uterus. So they're measuring the fundal height. And then again, assessing fetal heart tone, so tracking baby's heart rate. Weeks 19 to 24, still having those monthly visits. During this time, the provider may give the patient the option of fetal abnormality testing. So some genetic tests are done at this time. A lot of those are optional. You don't have to have those done. For my pregnancies, we opted not to have genetic testing done, but the patient has the choice a lot of times. And then around this time, around 19 to 24 weeks, you'll have an ultrasound to look for fetal anomalies and if there are multiple fetuses within the uterus. So a lot of times patients won't have an ultrasound until this 19 to 24 week mark, right? The first time they actually get to see baby through the ultrasound machine. 25 to 28, still doing those monthly visits, still looking at weight, still looking at the fundal height, the heart tones. Here, though, we will add on a gestational screening, gestational diabetes screening. Here, the patient will ingest a very high sugar drink, and they'll have their blood sugar tested. And what they're looking at is if that patient's body is able to decrease that blood sugar range, even though they've ingested a very high sugar quantity item. So they're making sure that this patient is not at risk for gestational diabetes. If the patient has a certain blood type, if they have a negative blood type, like they're AB negative or A negative, this patient is going to need an injection of RhoGAM. And again, this is something that those first labs will tell us is the type of blood test that the patient is. They'll also ask for the partner's blood test if you know that. Obviously, some patients might not know their partner's blood type. Weeks 29 to 34, they're going to go bi-weekly, so every 2 weeks they'll be going to an appointment. Here we're still looking at fundal height, looking at vital signs, especially making sure that blood pressure is not increasing, looking at weight, and then assessing fetal heart tones again. And then between 35 weeks to delivery, and remember 40 weeks is our full gestational term, we're going to go every week. So for 5 weeks, essentially 35 to 40, they're going every single week to be checked. And then at the very end, closer to the end, starting at this 35 week, they'll start doing a pelvic exam. And they're looking to see if the patient is dilated, how their cervix looks. They're also testing for something called Group B strep. It's a type of strep that can occur on the cervix, and they want to make sure that baby is not going to be exposed to this coming through the vaginal canal. And so they do that test on the mother. It's a swab. They swab the cervix to test for Group B strep. Now, if that comes back positive, the baby and the mother will both receive antibiotics at delivery. So those are our subsequent prenatal visits throughout the term of pregnancy. Now, here are some disorders that can occur throughout pregnancy, and some of these I mentioned previously, but one can be abortion. So this is any type of interruption of pregnancy before the fetus is viable, meaning before the baby can live out in the external environment on its own. So this can actually be spontaneous. It just occurs naturally on its own, or it can be intentional, right? The patient chooses to have an abortion. But this is any interruption of the pregnancy, death of the fetus before that baby is viable for life. Ectopic pregnancy, this is implantation of the embryo outside of the uterus. This baby will not make it, right? Oftentimes this is when the baby implants itself inside the tube of in between your ovaries and your uterus, and this is life-threatening because a baby's not meant to grow and sustain life that's not inside the uterus. So anytime it implants itself somewhere other than the uterus, it's called an ectopic pregnancy, and as that baby tries to grow in that area, it can cause ruptures within that reproductive system, which causes internal bleeding, and this is a life-threatening condition to the mother. But any baby that's through an ectopic pregnancy, they will not make it to be a viable pregnancy. Eclampsia, this is pregnancy-induced hypertension, so high blood pressure, and it can result in convulsions or seizures. There's gestational diabetes, which I mentioned, which is elevated blood sugar during that second and third trimester, and every pregnant woman will be screened for that gestational diabetes. Hyperemesis gravidarum is excessive vomiting during pregnancy. Sometimes this occurs and patients have to be put on antiemetic medication like Zofran. Sometimes it's so bad that they have to be hospitalized for this condition to receive fluids and to be put on a medication pump that distributes this medication so that the patient can eat and actually get substance to that fetus. Placenta previa, this is where the placenta implants very low on the uterus, and it may even cover the opening of the uterus to where the cervix is. And this is can be threatening for when you go into labor, and it's important to know where the placenta lies, because if you go into labor and you deliver the placenta first, the baby will not make it through delivery. So we want the placenta to be higher up on the uterus so that when delivery occurs, the baby comes out first and the placenta comes out second. Placenta abrupto, this is where the placenta prematurely and abruptly separates from the uterine lining, and this can cause life-threatening consequences to both the mother and the baby if this occurs. Impaired fertility. This is very common nowadays, the inability to conceive or bear a child after a period of unprotected sex. Many times OBGYNs, physicians want you to try to conceive naturally for at least a year before they start looking into other options to help fertility and conception of fetuses. And then incompatibility. This is where I was talking about that RhoGAM injection and when the mother has a negative blood type. And so this is when the mom has a negative blood type and the baby has a positive blood type. There's an interaction that can occur and can be life-threatening. So that's important for us to know what type of blood the patient has and if they need to have that injection. Okay, so the last part of pregnancy obviously is that labor and delivery and postpartum period, right? So labor is the process during which the uterus contracts and it causes those contractions to help expel the fetus and the placenta. So there are 3 stages of labor. The first is dilation. This is when labor starts, so the onset of labor, until the completion of dilation and effacement of the cervix. So you often hear in medical shows or just, conversations, they were 3 centimeters dilated, 4 centimeters dilated, right? And so it's from 0, so not being dilated at all, to 10 centimeters dilated, and that's full dilation of the cervix. So that patient is ready for the baby to be expelled. Stage 2 is expulsion, and this is once the patient is completely dilated and there's effacement for birth of the fetus to occur. And then stage 3, after the fetus has made it through the birth canal, then they will expel the placenta. So birth of the fetus to the expulsion of the placenta, and that finishes the labor process. And then following labor until 6 weeks past labor, this is the postpartum period. So 4 to 6 weeks after delivery, we usually follow that 6-week time period. And this is when the uterus is returning back to its normal size, right? So with this baby, the uterus has expanded to house the baby, and it's going to be contracting and getting back to that normal size within our bodies. And there's a need for good nutrition at this point, right? We want mom and baby to be healthy, and we need to provide optimal nutrition, especially if the patient is breastfeeding. And then emotional adjustment, because there are some hormonal shifts that occur, obviously, with the pregnancy ending and entering that postpartum period. There's going to be a lot of hormones going on. So knowing that there are some emotional adjustments that may need to be made. So that covers obstetrics and labor and delivery, as well as our postpartum period.